guys.
Are perfectly fine.
Perfect. So what I'm going to do is I'm going to load the share screen. Okay. Cool. Okay. So we have a lot of slides to get through. So I'm going to get started. Can everybody hear me okay, it sounds like, and can you see the screen properly?
Yes.
Awesome, very good. Okay, well, so without further ado, I'm Frank Penna. I'm a pediatric urologist. I'm new to the institution. I joined here in mid-May, just a few months ago, amidst this crazy time. But everything's going well so far. This is my first virtual talk. I've given many talks in my career. This is my first virtual talk, and I do appreciate the opportunity to give you some insight into a little bit about what I do and kind of how both of our fields overlap. You know, pediatric urology and nephrology, we kind of go hand in hand in a lot of ways. And I often call myself a plumber when I describe what I do to the patients and differentiating what I do from what the pediatric nephrologist does. Anyway, we're going to talk a lot about the plumbing today. Without further ado, I'm going to proceed. Just to give you a little disclaimer, there's some sensitive material here, possibly some images of children's genitalia, etc. At some point during the talk. Just a little disclaimer, it kind of comes with the territory. I just wanted to let you know, I'm sure you're already anticipating this. A little bit about myself. I've had the privilege of training at some of the finest pediatric institutions in the world. I did a research fellowship at Boston Children's Hospital and Harvard Medical School. I did my clinical fellowship at the Hospital for Sick Children or Sick Kids in Toronto, where I spent 2 years. The second year was basically a basic science research year in the research tower, which was an excellent experience. I recently joined the faculty here from Dartmouth in New Hampshire and the Children's Hospital at Dartmouth, which is CHAD. I mention that because I built up a program there where I was essentially providing minimally invasive surgical services, robotic surgical services to children, which is kind of unique. And I bring that here as well, just to show you an image of the robotic room. This is during my training in Detroit, I did my residency at Henry Ford Hospital in Michigan. And this is our robotic room there. It's kind of a one-of-a-kind kind of place, large 120-inch screens that are in 3D as far as the visualization goes. You have to wear 3D glasses when you're assisting at the bedside off to the right. I'm off to the left at one of the consoles operating on the patient, which is actually way off into the right underneath the surgical system device. Patient's kind of lost in there. But it's a great tool, and I'm able to offer that to even infants and do reconstructive surgery on their urinary tract using this very sophisticated tool. And that's my attending off into the distance on the left, just kind of watching me operate and supervising me from a different console. So just a really amazing piece of equipment that I have the privilege of using, and just wanted to share that with you. An area of research that I'm interested in is innovative device development. Just to show you a prototype of something we designed when I was in Toronto this is on the topic of obstructive uropathy. And on the topic of obstructive uropathy, it's always nice to find drainage tubes and catheters that work better for the pathology. And so what we did was, we ended up publishing this, but we reappropriated a ureteral stent, which is meant to go from the kidney to the bladder. We reappropriated it for lower urinary tract drainage from the bladder to the outside world, kind of like a Foley catheter, but overcoming some of the limitations of a Foley catheter, as well as overcoming some of the limitations of the other common catheter that we use in children and babies, specifically a feeding tube. And this is the device shown here. It has this is a kind of a redundant curl because this is a transplant stent, and it's a little baby here. But you can see it's basically, it's got two curls. It holds it in the bladder. We did this, we showed this, we demonstrated this in a series of babies with posterior urethral valves, which is one of the topics I'm going to discuss with you today. And we're able to insert it with the assistance of a guide wire rather than just blindly, meaning just like you would pass a Foley blindly. This is kind of a guided catheter insertion, so to speak. So it's able to overcome the valve tissue during a difficult catheterization, which occasionally happens when you try to decompress a baby that has valves. It's sometimes hard to get the catheter into the bladder, and hence you call me. And this is one of the things that I would offer. It's able to be visualized on an X-ray as well as ultrasound, as you can show, as I show you here. We did further studies on the drainage of this specific tube and looked at how quickly it drained urine from the bladder. I used water from a balloon, but same idea in that it drains 18 times faster than a Foley and about 6 times faster than a feeding tube, which is kind of arguably a better drain. So this is kind of one of the areas of research that I'm interested in, and kind of helping our patients and applying novel devices to kind of overcome some of the limitations of what's currently available. So moving on, I left Dartmouth after I designed a biodegradable ureteral stent, which basically is of great benefit, not just in children, but in all patients, but specifically children, because to remove these internal stents after reconstructive surgery or after kidney stone surgery, we have to go back in and do a second operation. Even though it's a quick one, it's still under general anesthesia. And this is a way of providing, basically allowing the stent to dissolve on its own, just like suture material. And so we designed a few prototypes regarding this, kind of modifications of the double J stent shown on the left, other ways of holding it in the urinary tract and making it easier to dissolve. So just another idea, just to kind of give you an idea of what things we look at and what things we can improve upon in how we treat our patients. So just to give you a brief outline of what we're going to be talking about today, these are the heavy hitters here. Obstructive uropathy is a huge topic in urology, covers a lot of conditions. There's a lot of information that's really, vested inside this topic. So I'm going to try to briefly get through all of these and touch upon the heavy hitters, the things that you should know and that you should be aware of. So a little bit of embryology, which you cannot do in a pediatric urology talk. Embryology is so important. As a medical student, I was always overwhelmed with all of the idiosyncrasies and gene names and everything like that. I think for our purposes, it's really a matter of applying it clinically and allowing us to understand where the embryological development process went wrong and how it could lead to pathology that we actually see and we have to treat, and we can treat and fix. Prenatal detection, UPJ obstruction, ectopic ureter, megaureter, related but different, ureteral seals, posterior urethral valve, which I mentioned already, anterior urethral valve, very rare, but still something to show you some pretty pictures, and the role of circumcision, if we have time to get to that. So embryologically speaking, the development of the urinary tract is obviously complex. This is a very rudimentary picture showing the development of the kidney as it comes from mesoderm and showing the ureteric bud, which is part of the lower urinary tract in the ureter, and how that connects with the kidney and the metanephric mesenchyme. At roughly 10 weeks gestation, you basically have the kidney there with the formation of the minor calyces. Off to the right is the development of the lower urinary tract and the bladder, the trigone, the seminal vesicles, and vas deferens in boys and men. And just to show you, this is a complex process, but this is where things can go wrong, and that's sort of what we need to know, understand a little bit at least about this, so we know why they went wrong, and have an understanding of the pathological process that results from this detour from normal. Moving on here, just to show you a close-up of kind of what I was talking about, the ureter and trigone. This is lower urinary tract development. And the ureter buds from the mesonephric duct there, as you can see. And it's usually an optimal distance from the urogenital sinus, which down below you see, that sinus eventually will become the bladder. And then the duct, the mesonephric duct, and the ureteric bud then separate, and they enter the urogenital sinus and then they separate. The ureter moves craniolaterally, and the mesonephric duct moves caudalomedially to form the ejaculatory duct. It moves down, and then the ureteric bud moves laterally. Right? Why is that important? Well, if the bud is too close to the sinus, what happens is it migrates too far, and therefore it can result in vesicoureteral reflux. So, in other words, if it migrates too far, that the ureter is not tunneled enough into the bladder, and it's too superficially inserted, and therefore it's not a good anti-reflux mechanism that should be naturally built into the ureter and its connection with the bladder. If the bud is too far from the urogenital sinus, what happens is it delays the separation and of that from the mesonephric duct, as the mesonephric duct moves caudally, and it kind of carries it with it. So it drags the connection with the ureter and the bladder medially, which can result in basically an ectopic ureter. In other words, a ureter that's inserting into the bladder in the wrong spot, and most of the time in this situation it's medially, and it could be in the bladder neck, or it could be in other structures as well, depending on how close it is to that, or how far it is from the urogenital sinus, so to speak. If you have two buds that come off, you have a duplicated collecting system instead of just a one bud. If you have persistence of this, what we call Chihuahua's membrane, that's a board question in urology, just so you know. I don't know if it's a board question in nephrology, but it might be. But if this Chihuahua's membrane persists between the ureter and the urogenital sinus, it results in something called a ureterocele, which I'll talk about. So we touched upon a few things here: reflux, duplicated collecting systems, ectopic ureters, and ureteroceles. These are all topics that I'm going to get into. It all is based on that diagram that I just showed you. Prenatal detection. Fortunately, with our fancy ultrasound, we can actually detect a lot of conditions, or at least get a heads up prior to the baby being born. You know, we can understand a little bit about what's going on in utero, because all of this happens at 10 weeks, most of it. So we can get a sense early on what's going on. You can see hydronephrosis on prenatal ultrasound. You can see cheliectasis, which is like just chelicele dilatation, pelvic dilatation. You can measure an AP diameter to get a sense of how dilated the renal pelvis is. You can get a sense of the renal parenchyma, how healthy it looks. All this information is available with prenatal ultrasound. Urothelial thickening. You can look at duplicated collecting systems. Cystic structures like a ureterocele you can see very clearly on prenatal ultrasound. And a keyhole sign, which is associated with keyhole, looks like a keyhole because it's a dilated posterior urethra, and that's pathognomonic or associated with posterior urethral valves. Just to give you kind of a snapshot of different findings that you can detect prenatally. What does this all mean? Well, if you find antenatal hydronephrosis, you can correlate it with pathology depending on the degree of swelling. Mild, 11-fold increase, 11%. I'm sorry, it's percentage. So as you basically, just the gist of this chart says that as you get more severe hydro, antenatally, it's higher. There's a higher correlation percentage-wise with pathology. Any pathology or specific pathologies listed here. Like something like an obstructive process, like a UPJ obstruction, the second item there. Severe hydro, it's a 50% chance that that boy or that baby actually has a UPJ obstruction. Reflux is less correlated with hydro, and that's because you don't always see hydro reflux at all. It could be a completely normal ultrasound, but the boy or girl could have reflux. And valves, it's dependent. But just to give you an idea that you can kind of counsel the parents early on with this information. This is a very complicated chart. The whole point of me bringing this up is to show you that you can really have urinary tract obstruction anywhere in the urinary tract, even from within the kidney, the infundibula, the pelvis. We're going to focus more on the UPJ, the ureter, and the bladder and urethra at this point. But there are conditions, and we're going to focus more on congenital conditions. Obviously, there's other conditions that can cause obstruction that are acquired, obviously malignancy and such, calculi, and those are things that we treat. As a pediatric urologist, it's mostly, for me, it's mostly congenital conditions, some acquired like stone disease I treat in kids, but most of this is congenital conditions of the urinary tract. This is a very helpful diagram demonstrating to you the SFU grading system for hydronephrosis, so we can speak somewhat objectively about how much swelling is present within the kidney. And what's nice about this little diagram here is it's got a cartoon version and an actual correlate with the actual renal ultrasound, so you can get a sense. It's easy to remember the appearance of the cartoon because it's so, simplified in that sense. But ultrasound's pretty simple and very clear in general anyway. And something simple with no radiation, you can get such helpful information. It's not a functional study, an ultrasound, but it's kind of a gateway modality. It's a gateway imaging modality for other imaging techniques that we can implement or we can order and request based on the findings on ultrasound. If we're concerned, we can get a diuretic renogram or a MAG3 scan or a DMSA scan or a VCUG, which I'm going to be talking about later. Just to go over 0 through 4, it's very clearly demonstrated here visually. Moving on here, let's just talk a little bit about UPJ obstruction. That's a nice cartoon just demonstrating it. It's really described as a stenotic area, or for lack of a better phrase, a congenital scar, so to speak, between the pelvis and the ureter, which leads to dilatation, proximal dilatation above it. And so we're just moving on, just a couple salient points about it. It's definitely the most common lesion that we see as far as obstruction goes. I want to differentiate between intrinsic versus extrinsic. I mentioned intrinsic with the scar tissue, the congenital scar tissue. That means that there's something wrong with the inside of the plumbing. It didn't properly cannulate in order to drain the pelvis, the plumbing properly. Extrinsic means it's coming from the outside, the obstruction. And that's classically described by a crossing vessel, an anomalous renal vessel that didn't go away during development. Again, development being so important in causing disease. And so extrinsic presents differently than intrinsic. Intrinsic is typically picked up by prenatal ultrasound. Extrinsic, younger patient, baby or young, early under 1 year typically, and I'll repair it. The older kids typically have the extrinsic. They get it later. And I'm going to get into something called the Dietz crisis in a second. And you'll see how that manifests differently. The babies are probably asymptomatic. Maybe they might have an infection. Most of them don't. And they just, all this is picked up because of prenatal ultrasound. That's why I mentioned it, because it's so important. Usually it's without a dilated ureter. That's because the obstruction is proximal. It's in the urinary tract. It's not really involving the lower ureter because the ureter is fine. The connection between the ureter and the bladder is fine. That's a different condition. We're going to get into that in a minute. 10% are bilateral. I have repaired them bilaterally. It is a partial obstruction. You know, if it was completely obstructed bilaterally, the kid wouldn't make it. It is a partial obstruction. It's a spectrum, just like all of the conditions that we treat. This is an ultrasound showing dilatation. This is grade 4. You can see the pelvis is quite enlarged in the lower part of the image there. The black is urine. The calyces are also dilated. I mean, the kidney is huge because of the dilation. So this is significant, severe hydronephrosis. This is just a little snapshot of one image from a diuretic renogram. A diuretic renogram is also called a MAG3 scan or a renal scan. It's got like 25 different names. Really, it's a functional study. We order it when we're concerned about the ultrasound and how severely dilated it is, or the kidney is, because I want to get more information. 2 pieces of information I get from a diuretic renogram like this. One piece of information is not shown on here, but it's differential renal function. Should be 50-50. In a kid who's really obstructed, there's a decent chance, even early on in life, that kidney is probably not 50%. It could be 40 or 30. The other kidney making up the difference between being 60 or 70. So that's helpful, because a kid that has diminished renal function on the ipsilateral obstructed side is another good reason to repair it. Off to the right is how well that kidney is draining. This MAG3 is injected. It's processed by the kidneys. How quickly it gets uptaken is how well it's functioning, and how quickly it drains to the bladder with a T-half, we call it, or a half-life, gives us an idea of how obstructed quantitatively the kid is. T-half of greater than 20 minutes is considered a higher grade obstruction. But you have to look at all the data yourself and come to that determination, because every test has its limitations and it's not perfect. So you got to really, look at the images yourself and come to that determination. Don't just read the report. This is somebody I alluded to earlier. Why do I show you a picture of him? I think it's a little bit of history of urology is kind of interesting. This is Joseph Dietl, hence the Dietl's crisis phrase that I mentioned, that term. He was an Austrian-Polish physician in the mid-1800s, and he first described Dietl's crisis, which is an episodic pain crisis for kids with an extrinsic, most of the time it's an extrinsic obstruction from a crossing vessel during periods of diuresis. Okay, so what happens is the kid's usually fine, no symptoms, and then all of a sudden they may, this happens sometimes as late as college kids who start, binge drinking or drinking alcohol, and they diurese, and then it challenges that narrowing that's being extrinsically compressed or caused by an extrinsic compression, and it causes pain. It causes acute pain, vomiting sometimes. Anyways, that's something to know about a Dietl's crisis. Those kids I would repair in the same kind of way as I would repair the kids with an intrinsic. There's several different techniques. This is the main technique that most people use. It's called a dismembered pyeloplasty. What we do is we basically, if you see in letter A, part of the diagram, there's a stenotic area. You can clearly see that. We basically excise that area, and we spatulate the ureter so it's a little wider, so it can meet the defect in the pelvis, which is wide because the pelvis is quite dilated. But once you decompress it a little bit, that pelvis is like a stretched balloon. Initially, it does decompress more than what this diagram is showing. So it is easier to sew when it's decompressed because it's smaller and it'll meet that ureter. And then we sew it up. I usually run 2 stitches. You can do it open. You can do it straight laparoscopically with small incisions, or I usually do it robotically, as I showed you in that first image of me in the operating room. It's a great tool for repairing this particular condition or fixing this problem. And you can do it at any age, even in adults that are having symptoms, which sometimes happens. But most of the time we get them young and fix them up. Anyways, ectopic ureter, going back to a little bit of embryology. So the ureters invert the position as they fuse with the sinus. So it becomes a little bit so basically, just starting from the very bottom here. So what happens is if you have a duplication, for example, you have two buds, like I mentioned to you. They grow from a single mesonephric duct, okay? And then what happens is they invert their positions. And I'm going to go over that in a more clinically relevant way. It's called the Weigert-Meyer rule, which is important. It will help you remember in a duplicated system which ureter feeds the upper pole and which ureter feeds the lower pole in relation to how it inserts into the bladder, okay? Anyways, the whole reason why it's a little bit backwards, what I'm trying to say is the upper pole inserts inferior medially. So you would think the upper would insert higher in the bladder, but the upper pole of the kidney, its ureter drains inferior medially, so actually lower in the bladder. And that's what that relationship was just describing to you. And those typically would be ectopic ureters inserting into a bladder neck or a ureterocele. So upper pole typically obstructs because you're getting a more medial insertion into the bladder. That's important to remember because upper pole hydronephrosis is probably an obstructive process in a lot of cases. Lower pole, superior-laterally. Okay, so lateral is the main importance there. It's a lateral insertion with the lower pole. Why is that important? If it's inserting laterally on the bladder, it's not a long tunnel, so it has the tendency, I'm trying to think of the word for that. It has the possibility, it's the predisposition to reflux because it's a lateral insertion on the bladder. So that's just called the Weigert. Oh, this is just showing you it can insert anywhere on the bladder. Excuse me. It can, in male and versus female, it has multiple different insertion sites. It's not always the bladder neck. The ureter can insert into the prostatic urethra, as further down a bit. In the female, it can insert into the vagina, and you can have a ureter that's either draining or obstructed when it connects to the vagina. That's another pathological manifestation of an ectopic ureter, and we can see it in the vagina. And the little girl could be leaking urine all the time, for example, and it could be coming from that part of the kidney with that ureter into the vagina. Even though she's voiding and continent from her bladder, she's leaking into her vagina. If there's a functional part of the kidney that's making urine and draining it, and it can drain out of the vagina that way. And that's something we would look into. And an MRI, for example, would be a way of helping us to diagnose that. Just a variation of how this can present. Weigert-Meyer rule, just what I said. Upper pole, possible obstruction, but inserts medially, like in a ureterocele or a bladder neck inserting ureter. Lower pole, lateral, could be normal, but also has the predisposition to have reflux. We don't know. It all depends on how laterally it really inserts. So that's the Weigert-Meyer rule. This is a patient I treated a few years ago. As you can see on the right side of the image, the left kidney, you can see a significant portion of the upper pole of the kidney has urine in it, and it is obstructed. That's an upper pole, that's the upper pole part of the kidney. It has an upper pole ureter in a duplicated collecting system, and that ureter is draining into the vagina in this female. If you look down towards the pelvis, you see that bright midline structure is the bladder. That's contrast in the bladder. Look at the black and gray area below that. That's urine, or that's the ureter as it's inserting into the vagina below that. So I ended up removing this upper pole kidney, and I removed the upper pole ureter all the way down to the vagina and clipped it off. The girl was 18 years old, and she all of a sudden started having infections. And it was because of something must have seeded, some bacteria must have seeded this obstructive process that she was having, and we couldn't clear her of the infection properly. This is a VCUG, so that's a voiding cystourethrogram of a lower pole moiety. This is a refluxing lower pole moiety. It's called radiographically a drooping lily sign. And why is that? It's because the upper pole is not lighting up at all, because the upper pole is not a refluxing moiety. You see the upper pole is above, and the lower pole is kind of getting pushed down some by that upper pole there. The upper pole, I think, in this child is a bit obstructive, so it could be dilated and pushing down. So you have upper pole hydro with possible obstruction due to an ectopically inserting ureter, and a lower pole reflux, just demonstrating the VCUG showing lower pole reflux. VCUG quickly is avoiding cystourethrogram. You put a catheter in the patient, you instill the bladder with contrast or X-ray dye, and you take pictures of the bladder as it's filling to get a sense of if there's reflux. You also do a voiding phase where you see the child void, and you can get a sense of how the contrast fills the urethra to make sure they don't have other issues with the anatomy beyond the bladder, between the bladder and the outside world, including a condition like posterior urethral valve. You can see a very dilated urethra. I'll get into that later. We have a lot more to cover, so I'm going to keep moving here. This is an intravenous pyelogram. We don't order these a lot. For this kid, I ordered it because I wanted to get a better sense. I mentioned VCUGs only show lower pole reflux. You can't see the upper pole. Intravenous pyelogram would get contrast into both units from above intravenously, right? So you could see those two arrows are pointing to the two ureters as they're coursing down to the bladder. One ureter is much more dilated than the other. And what I did in this child is I sewed the upper pole ureter to the lower pole ureter here and did a ureterostomy. So I told you I remove the unit sometimes, but if they have enough function, I can redo the plumbing so that everything's draining into a non-obstructed system, nice, or a non-refluxing system, depending on if I'm sewing upper to lower or lower to upper for the patient. Okay, so we talked about UPJ obstruction. We talked about ectopic ureters, the Weigerd-Meyer rule, and how they insert into the bladder and how we treat these conditions. By the way, if it's not obstructed, okay, and you have a duplicated collecting system, it's not obstructed, it's not refluxing, you can just watch these kids. I mean, we worry about obstruction because we worry about renal damage from obstruction. If it refluxes, we don't care about reflux unless the kid's getting infections, and that's a source of the insult. That's the issue with kids with reflux, is that they get recurrent febrile urinary tract infections. That's what damages the kidneys. So the only time we treat these things, if we think they're obstructed, because we don't want the kidney to lose function over time, and then reflux, we treat it only if they're symptomatic with reflux, like they're having infections. Megaureter. Any large ureter, it's a condition that describes that the ureter is dilated. It could be primary or secondary. It could be secondary to a bladder pathology that's causing dilatation of the ureter above it. Primary means the ureter is just dilated because of its own pathological process. You can have obstructing megaureters. You can have refluxing megaureters. You can have non-refluxing, non-obstructed megaureters, believe it or not. So just kind of breaking it down, this chart breaks down. It's a little complicated, but if you just keep it categorized the way it is, in refluxing units, it's mainly due to primary vesicoureteral reflux. Okay, and that's a refluxing megaureter, and that's a case where reflux is causing enough dilatation of the ureter that it's big enough to be called a megaureter. Like I said, reflux doesn't always dilate the ureter. If it's lower grade reflux, you might have a normal ultrasound. Anyways, this just kind of breaks it down nicely. There's an primary obstructed megaureter is something we see, meaning the connection between the ureter and the bladder is too narrow, and therefore the child has a very dilated ureter proximal to that, and everything above it is dilated. And then non-refluxing, non-obstructed megaureters, nothing to do with those, because like I said, they're just big ureter, but they're draining and they're not refluxing and not putting the kid at risk for infections. So you can watch these kids, you can operate on them. And when you operate determines, like I mentioned, if we think they're obstructed or they're getting infections and they're refluxing. You can do it endoscopically and in size from the bladder. That's not very commonly done, but that's another way that's kind of, minimally invasive. But really when to intervene: infections, stones because of obstruction, or worsening of the hydro where we think it's obstructed. The initial ureteral diameter is correlated with how likely it is to resolve. So the more dilated it is, in this little snippet here, if it's greater than 1.5, closer to 2 centimeters dilated, at its maximum diameter, usually closer to the bladder is where it's maximally dilated because of where the obstructive process is. Those kids are less likely to resolve and more likely to have undergo an operation. Just to kind of counsel patients and stratify it. We watch a lot of these kids and wait, and see and get serial ultrasounds and order diuretic renograms to see how they do before we go in and intervene. This was a consensus statement on how urologists in general manage primary obstructive megaureter. I mentioned refluxing ureter, that we wait and watch and only reimplant or fix those ureters if the kids are symptomatic. But obstruction, we usually, fix that. What we determine as an abnormal ureteric diameter, ureteric is the British term for ureter or for ureteral. They call it ureteric. We say ureteral. But anyway, the ureteric diameter greater than 7 millimeters, that usually flags it as a megaureter. But a lot of the docs here will start the kid on antibiotic prophylaxis. Young babies can get sick very quickly, and it can go from a urinary tract infection to a bloodstream infection to a central nervous system infection very, very rapidly because the immune system is still, developing and getting acclimated. So prophylaxis is not a bad thing for the first couple of months. I'm not a huge fan of antibiotics, but the worst thing to do is to have a kid with a fever who's so young that you have to have an LP done on, for example. I mean, it's a lot for the family to have to go through. The kids should get an ultrasound postnatally and should get a VCUG to see if not all kids should get VCUGs. But kids with this degree of megaureter, it's worth looking at to see if this kid is an possibly obstructive megaureter or a refluxing ureter. The VCUG will help us determine if it's a refluxing megaureter. And then we'll selectively order a MAG3, a diuretic renogram, in the kid if we're concerned for obstruction. So they came to the conclusion that mainly, like I was saying before, febrile UTIs is a reason for doing something. We don't want that to damage the kidneys if kids are older and having pain. If there's a decrease in or a lower differential renal function associated with this, obviously if we think our kidneys are getting damaged by the obstruction, then we should do something. Or if there's a decrease in that over time, like a trend down in how well that kidney is functioning. And then they recommend doing it above 1 year of age. So this is not something we rush in to do right away. We would fix this problem, as we really determine how severe it is, because a lot of the kids, believe it or not, with antenatal hydronephrosis in general, a lot of the kids resolve. And so it's really important to make the parents aware of that it doesn't necessarily mean that it's going to result in a surgical procedure. The way I put it to them is that the kids usually declare themselves to me. The kids will tell me if they need surgery. So it makes it a little easier because, it's those clear indications that make me have that conversation with the families to do something. This is a ureteral seal. And this was that persistence of Chihuahua's membrane embryologically when we were speaking. This can be broken down. You can have a single system ureteral seal or a duplicated system, and it's usually associated with the upper pole, like I mentioned to you, and that's based on the embryology. It could be obstructive, could be blocking that ureter and causing upstream dilatation, or it could be non-obstructive. It might not really be causing it, and then we just don't need to do anything about it unless the kid's having infections. It's usually presenting prenatally. It can present with an abdominal mass if it's large enough. It could present with UTI because if it's an obstructed process and that urine gets seeded with bacteria, it's hard to clear that when it's not draining properly. It could also prolapse out. That is one of the, on the differential, that's one of the conditions that we see. That is, that's one of the conditions in the differential for a mass, a perineal mass like this. And this is a ureterocele prolapsing from the bladder. Anyway, what do we do for these? Well, this is just an ultrasound showing a duplicated collecting system, upper pole hydronephrosis because it's an upper pole moiety that's obstructed by the ureterocele, and on the right is the ureterocele in the bladder. Okay, so this kid is obstructed. That's a single system showing you there. By the way, this kidney is not functioning very well. This is a patient I had in Toronto when I was a fellow. That kidney is quite dilated. It's a single system ending in a ureterocele. We made the mistake. This is a DMSA scan, which is another nuclear medicine scan that looks at scarring in the kidney and function. Okay, function of the kidney, differential function, kind of like a MAG3 too, but a little different. Doesn't show drainage. Anyway, this kid, obviously, like I said to you, has poor function, 4%. We made the mistake of incising this kidney. Or excuse me, I misspoke. Incising the ureterocele endoscopically, cutting it so it drains. Problem is, we created reflux. That's one of the complications. It's about 25% of the time when you incise that ureterocele endoscopically, you're gonna disrupt the usual ureteral vesicle junction it's not normal there because it ends in a ureterocele. So when you incise it, you're allowing urine to go back up to the kidney, and 25% of the time you're creating reflux. But sometimes the reflux is not symptomatic. So you might create reflux and then you don't need to do anything about it because the kid's not getting febrile UTIs. Why is that? Well, it's because the kidneys in most situations is producing urine. So you might be getting reflux up to the kidney, but the kidney is making urine, and that's allowing that to get washed out, down like running a sink, a faucet in the sink. It's constantly flowing and keeping the water running, or the urine running downstream. So even if a little bacteria gets up, it doesn't have time to build up in the urinary tract. But in a kidney that's not functioning very well, you're going to create something called stasis. And that is really the problem. That's the main problem in the urinary tract when it comes to infections. When you have urinary stasis somewhere in the urinary tract, even in the setting of reflux or obstruction, and the kidney is not draining properly, and there's bacteria there, then it's a setup for failure. Okay, so this kid kept getting UTIs because we couldn't clear that large capacious ureter that was draining that previously obstructed kidney. Anyways, we ended up removing the kidney, long story short, which was the right thing to do eventually. This is just showing an X-ray of a ureterocele. This is an IVP again, just showing a filling defect in the bladder. This is a ureterocele, just to give you another image of it. I mentioned incision. I mentioned removing the kidney or removing that portion of the kidney and its associated ureter in the case of a duplicated system. You can do that if the kidney is not functioning very well. If the kidney is functioning well, you want to leave that kidney there, but you want all the nephrons you can get. So you can do a UU, which I described to you, sewing one of the ureters to the other ureter and allowing all the urine stream to drain down the ureter that does not have the ureterocele associated with it. And you can just leave the ureterocele in the bladder and the kids can do fine. You can also do a UU in the case of an ectopic ureter that's inserting into the bladder neck that's obstructed. And you can just bypass that obstruction by creating a Y connection. And I've done many of these cases and the kids do phenomenally well robotically, 3 little cuts, and you don't have to mess with the bladder at all. You just redo the plumbing up north and everything is great. You can excise the ureterocele from the bladder. You have to cut up the bladder open and reimplant the ureter, redo the connect. It's a lot more involved, bigger surgery. Nowadays, you know, if you're doing surgery right, you're doing surgery less, and you're doing it minimally invasively. Okay, and if you know, that's the goal of surgery, is to not do it anymore. If you're doing it right, or doing it with less morbidity to the patient. Long gone are the days where we slice these kids open and make large incisions and have 12-hour operations and stuff, and they're in the hospital for weeks. I mean, that's old school nowadays. I'm going to skip this. This seems kind of redundant, just going through the different techniques. Let's move on to posterior urethral valves, which is 1 in 5,000. So it's not as common as the other conditions, but we see it pretty regularly. It's basically a persistent valve tissue. It's a flap of tissue that does not go, that is present in the posterior urethra, and it causes obstruction. Okay, it causes lower urinary tract obstruction, which then basically it's a bladder outlet obstruction in utero. Okay, this kid can't pee properly, can't urinate, can't make amniotic fluid properly, and so he could have oligohydramnios, lower amniotic fluid. He can have significant dilatation in both kidneys because it's a central process, right? It's midline. Everything above, and then the bladder also can be damaged from this as well. Not good. I mentioned that already, congenital obstructive membrane. There's a couple different types. That's not really important here, but it's going back to kind of the embryological origin of this. Just showing you, this is an imaging study showing a fetus in utero with, that's the fetus's bladder. I mean, you could see how big these bladders can get. They're not emptying well, and therefore the bladders are huge. The dilated urethra is there, and the kidneys are quite hydronephrotic as well. Not good for the kidneys, right? But also really not good for the development of the lungs, which we're going to get into, which is the main issue why these kids might not make it. Okay, we can fix the bladder issues and try to address. I mean, the kidneys might have not formed properly. The kids might develop chronic kidney disease early on in life, but what really gets them is the abnormal pulmonary development. I mean, if you can't breathe, there's not much we can do about that. This is a keyhole sign. This is showing you on ultrasound. This is pathognomonic for valves. This is showing the dilated posterior urethra there. And that's the level of the bladder. It's good to get an early VCUG in the kid with bilateral hydro. Okay, bilateral hydro in a male, you should get a VCUG. Why? We want to rule out valves. We don't want to miss valves. It's not always as dire of a presentation as what I mentioned with pulmonary and respiratory failure and stuff. Some of these kids have much milder symptoms. Okay, we got to get bladder drainage. I mentioned putting a double J stent in there. Obviously, classically, it's described as a 5 French feeding tube. There's limitations to putting a Foley in. The balloon has been described in the literature to obstruct these kids because even though you're decompressing the bladder, the balloon in a thicker bladder that's been obstructed for months, essentially can also get obstructed from a bulky balloon in a very thick bladder. These kids, most of the time, or a lot of the time, need NICU support because of the pulmonary hypoplasia I mentioned. Obviously, serial labs, you guys are great at doing that. And prophylactic antibiotics, I think, is reasonable, especially in kids with significant urinary tract dilatation. And, we usually ablate these kids endoscopically. Okay, so we not too long after birth, really, we get them drained, and then if they're big enough, I'll go in with a little scope and I'll basically cut that valve tissue and unobstruct them, put a catheter back in for a day or two, and then get it out, and then allow them to urinate on their own. That fixes the obstruction, does not fix the damage to the kidneys or the lungs. That requires much assistance from you guys because it's a lifelong process of monitoring and managing that. And again, every kid is different. Some are more severe than others. Anyway, if they're really small, I'll do a cutaneous vesicostomy where I bring the bladder to the skin and make a little hole. And basically it allows the bladder to drain if I can't get a scope in them because they're too small. Upper tract diversion, meaning diverting their upper tracts of the skin. That's not commonly done as much anymore. There used to be this philosophy that you had to do that if you divert it from below or drain from below and there was still dilatation above. There's a concern that there's always a concern that there's a lot of dilatation somewhere in the urine that's obstructed. And that's possibly true with these kids. They could, even though you drain the bladder, still have obstruction upstream due to this large, capacious, floppy ureter from the obstruction and the resulting architectural changes in the ureter. This is a VCUG demonstrating that very dilated posterior urethra with that large arrow. That's way too big of a posterior urethra than normal. I mean, than it should be. And the other arrow is showing you the valve tissue, which is not always visible on a VCUG. But this is a VCUG is diagnostic for posterior urethral valves. Okay, and it should be done in any male with bilateral hydro or hydroureteronephrosis, because a lot of times you'll see ureteral dilatation as well. Again, more images showing that very dilated posterior urethra coming, down to the valve tissue and then the rest of the urethra. Anterior urethral valves, rare. I can't exactly remember the incidence, but if posterior PUV is 1 in 5,000, I think it's more like 1 in 100,000. It's rare. This is a kid I saw in Toronto as well. Why is it different? It's different in the sense that where the obstruction is. It's not necessarily different in the treatment. In this kid, we also ablated. Diagnostically speaking, you're going to see dilatation of the entire urethra. In this case, that's what you see. It's not just the posterior. This was a delayed diagnosis in this kid. He came in with urinary incontinence into my clinic when I was a fellow, and it was something just didn't smell right, and I ordered a BCUG, and sure enough, he had anterior urethral valves, and we ended up ablating him. That's an endoscopic view of that valve tissue coming in. All right, moving on. The major cause of mortality in boys with PUV, I mentioned this, pulmonary insufficiency. That's important to know. The effect on the urinary tract, obviously, in the kidneys, it obstructs them. It can cause glomerular, I can never say that word, you guys are better at it, glomerular damage, which is reversible, but also it can actually result in dysplastic kidneys, which is irreversible. Okay, once the damage is done, you can't not do much about it. You just have to manage the chronic kidney disease. The ureter, hydroureteronephrosis, in some of the kids you have reflux. Actually, the majority, you have like a secondary reflux because the bladder is so dilated and distended that the pressure within the bladder is high, and you're getting pressure up to the kidneys and reflux because of the pressure, not because of a deficient valve there. Anyway, but a lot of times it gets better after you decompress the bladder. The bladder, you get a valve bladder essentially. You can get incontinence, poor emptying, poor sensation. The bladder is damaged. It shouldn't have been that big. You saw that imaging study with, I think it was an MRI actually, with the kid with the enormous bladder. That's just not, the bladder should not be that distended in utero. It's not good. It's not good at any time, but anyway, that has its long-term effects on the bladder as well, and the urethra there. I mentioned the lung, that's a major issue. If they get through that, we can usually, and how long is the degree of dysplasia, which makes sense. Can you guys hear me still?
I can still hear you.
Okay, great. The reason why is it just gave me a message saying my internet connection was a bit unstable. I'm trying to wrap this up. I just to talk. I'm almost done. I appreciate your attention and patience with me. I have a lot of slides here. Mentioned the most important predisposition to renal failure in kids with valves is dysplasia. Okay, and then obviously infections don't help. If they're still obstructed in some way, that's not good. Hypertension, all the other things that you guys know about that can damage kidneys is there too. But the real most important one for you to know is, the kidneys didn't form properly. There's not much we can do about that. Okay. Urinary ascites, reflux and dysplasia. I'm going to skip this part. I want to leave a little time for some questions. This is talking about a subcategory condition called VURD. Um, this one, this question basically asks you what to do if you don't have a little scope to put in to ablate the tissue. I mentioned this already. You do a cutaneous vesicostomy. That's the first thing you would do. We don't do a lot of them because our equipment's pretty good and we can get in there pretty quickly and get it taken care of. Developed bladder syndrome, I mentioned that already. We manage this a lot as in pediatric urology because, these kids, we want to, the main goal is to make sure their bladders are emptying well and that they're dry as they can be. We don't want them leaking and we don't want them damaging their kidneys and getting infections and stuff because their bladders are not functioning properly. That's what we do. We can do urodynamics and look at how well and to understand the bladder a little bit better. And that's what we often do. Antenatal intervention, we can intervene antenatally, by the way. And the main goal in doing so is to prevent the pulmonary hypoplasia by preventing oligohydramnios and therefore helping with pulmonary development early on. And we can put a shunt in a fetal center that can get a little shunt, which basically shunts the bladder into the amniotic fluid so it drains it. It's like a vesicostomy with a little catheter through it, basically. But it's still very controversial about how well that actually helps. This is just showing you how it's placed. It's not without risk either. It has a high rate of complications. But it's kind of a last ditch effort in a kid that, might not otherwise do so well because of this condition. So fetal surgery is very fascinating to me. It is very high risk, but it's nice to have it as an option. And let's finish with the talk with the role of circumcision. I have a couple minutes, it looks like. And why I mentioned circumcision in an obstructive uropathy talk? Well, mainly because circumcision has been shown to decrease the risk of getting UTIs, febrile UTIs, within the first year of life. So kids with reflux, not an obstructive process, but kids with reflux, I'll offer it if they're not already circumcised. It also has other benefits too. Decreased risk of sexually transmitted infections in men, decreased risk of penile cancer as well. And the AAP recommends circumcision loosely. The benefits do outweigh the risks there. This is an important slide. The number needed to treat, in other words, the number of circumcisions needed to be done to actually reduce the incidence of UTIs in normal kids, normal boys, no urologic abnormality, 111. But if you are selective with circumcision and make sure you definitely treat the kids that have uropathology, the number that you need to treat on those kids to have a good effect in reducing UTIs is 4 to 11. So in other words, you need to, circumcision is very commonly done still, but I think it makes the most sense if we're going to do circumcision at all, it's to do it in the kids that need it the most with uropathology. And because their UTI risk, it drops down significantly. I've had kids with high-grade reflux, for example, boys, circumcised them, they were getting infections, recurrent breakthrough infections. You circumcise them and their infections go away. It's amazing. And you don't necessarily need to treat them further, believe it or not. Anyway, I'm going to skip through this. This is just a slide describing how important healthy bladder habits is, how important healthy bladder habits are. Adequate fluid, this is stuff you probably tell patients all the time. Keep adequate fluid, which increases the urine volume, and get them to pee more frequently, treat constipation, have them make sure they're voiding properly and the little girls spreading their legs so they're not voiding into their vagina. And all these things can really help any kid with uropathology in reducing infections, because that's really one of the main indications why we treat them surgically if they're getting infections. If they're obstructed, damaging the kidneys, or if they're getting infections, which is damaging the kidneys, we treat them. So this is just a way of counseling them on making sure they frequently void properly, they have adequate water intake, they fix their constipation, which is a huge risk factor for infections, and that they make sure that they take care of themselves down there and spread their legs and keep clean. And that makes an enormous difference in raising the threshold for getting an infection. And like I say commonly, I'm a plumber, and urology is plumbing, reliable intake, meaning getting enough in the tank to flush things out, and making sure everything's draining properly is the mainstay in reducing morbidity from the pathology that we see. Anyway, I'm going to finish with that. I think I finished pretty much right on time, maybe a couple minutes over. I apologize. This is my name and title and contact information, my mobile number, and my email. Feel free to take my number down. If you call me or text me, I prefer that. It's just direct, it's easy, and I prefer to know than to not know. So thank you very much for the opportunity. I'll open the floor up to questions. If anybody has any questions about anything I talked about. Okay, I guess I did a good job explaining everything. Again, this was a very extensive overview of uropathology, obstructive uropathology. I tried to touch upon the main topics. Probably was a little bit too many slides. I apologize for that. But I hope this helped. Again, if you have any questions that come up or any patients you'd like to discuss, please feel free to contact me. And again, I really appreciate this opportunity. It's been a pleasure. This was my first virtual talk I've ever given, so it's a little unusual, but because I can't even see your faces. But I hope you enjoyed it.
There's a question in the chat box.
Okay. Oh, I see. Okay, yeah. So I'll just read it out loud. I don't know if everybody can see it, but it says, thank you for your lecture. What is the negative predictive value or sensitivity of a VCUG, for instance, if the patient previously had a negative VCUG, but then continues to have recurrent UTIs or pyelonephritis? When would you decide to repeat a VCUG? That's an excellent question. If a VCUG is done properly, okay, and I can't stress the importance enough of a properly done VCUG, then usually you can have your answer right off the bat. Interestingly enough, you can have kids. You can have kids with reflux that never get an infection. Okay. If you were to do a VCUG on every kid in America, in the United States, you would find a lot of reflux and a lot of kids that just never get an infection. And then you have the kids that don't have reflux and they continue to get infections. And so it's really what it is. And that's why at the end of the talk, I talked about other risk factors for infections, circumcision in reducing it, and healthy bladder habits and healthy bowel habits in reducing the risk. That's so important because a VCUG is just one piece of the puzzle, okay? It's really just one clue, but I think it has to be interpreted with the entire clinical picture. So, I don't think there's anything wrong with repeating it, but because every study has its limitations, and I think you have to also, if you have a kid with recurrent pyelonephritis with a negative VCUG, you need to really make sure before you order another VCUG that you're looking at all those other risk factors. Sorry, I'm long-winded, I apologize, but I just want to say this. So if you have a kid with reflux, let's say, that never had an infection, and all of a sudden they get an infection at age 6, that doesn't smell right to me. They've had reflux since birth, and all of a sudden now they're getting infections. So it's got to be something else that's changed. The reflux has always been there. Maybe they're constipated, or they're holding their urine for extended periods of time, and it's seeding or maybe they're not spreading their legs enough if they're a little girl, when they're urinating, and they're creating a nidus for infection. So you have to look at everything else before you order another x-ray, especially something morbid like a VCUG with radiation and a catheter for a little kid. I hope that answers it. Any other questions for me? All right. Well, listen, thanks very much. Again, don't hesitate to reach out to me. I love chatting about this kind of stuff. I love what I do, and I would love to have the opportunity to meet you guys in person at some point in the future.